It is also clear that there is a long distance between the MD Anderson Cancer Center and treatment in Italy. Let me say that I'm sure that not only the American people are able to stay close to the MD Anderson Cancer Center Innovative Clinical Trial. We get a bit of delay for the second section, but we are... Unfortunately, Felicito Ferrara doesn't come to us, so we can start immediately with the next session. I give the moderation to my great friend, Cristina.
Thank you, Giovanni, and thanks for inviting me to this session. I have the honor and the pleasure to invite the first speaker, because we have 3 women as next speakers. So keep in mind that they belong to both MD Anderson and the Italian community. I think this is very important. So the speaker is Professor Maria Paola Martelli, who will address the question of new target therapies in AML.
Thank you, Christina. I would like to thank the organizers for the kind invitation to this interesting meeting and start again with this question that actually is a rhetorical question today. And I would remind that, all this comes from the deep characterization, molecular characterization of acute myeloid leukemia and the recognition of the role of the single genetic lesions in the disease with some of the disease-defining genetic lesion and many co-occurring mutations. In parallel with the big steps reached in the molecular characterization and classification of AML, progress in AML therapy has not been as rapid as you know in the past 40-45 years. But then this is what happened. We have seen in the last 3 years the FDA approval of 8 new agents in acute myeloid leukemia, which are offering more options for more targeted treatment in many clinical trials. But this means also new challenges to our approach to diagnosis and management of AML. And this recent recommendation from the European Leukemia Net will probably be revised sooner than expected. Many are the challenges, but I think that one of the major challenges will involve the way we evaluate the response and the response criteria definition. And this thought comes from some observation we have made in our patients. And I will report our experiences with FLT3 inhibitors, which, given also the high frequency of this mutation in AML, are among the most used specific inhibitors in either clinical trial or also real-life clinical practice alone as a single agent or in combination. Many are available with midostaurin and gilteritinib, FDA approved, and show clinical activity. However, true complete remissions are rare using single agents, FLT3 inhibitors, while more common are the complete remissions with incomplete hematological recovery, the CRIs, and the morphological leukemia-free state. We all know that response criteria definitions response criteria are based on the morphological evaluation of bone marrow aspirate and CBC according to the international working group and international working criteria. And however, there is also a recommendation for the evaluation of minimal residual disease by either QRT, PCR, or multiparametric flow cytometry as a clinically relevant response parameter. Here I will present some representative cases of patients treated with FLT3 inhibitors which challenge this standard criteria. Here are patients with diagnosis of relapsed refractory ML with a mutation of NPM1, DNMT3A, and FLT3-ITD, which was started upon a failure of the first line of salvage chemotherapy on gilteritinib as bridge to transplant. This is the bone marrow before treatment, which showed the diffuse infiltration by leukemic blasts expressing all CD33 and CD99 at the flow cytometry, and at immunohistochemistry expressing cytoplasmic NPM1 and stained positive with an antibody specific for NPM1 mutant. The DNA fragment analysis showed 47% variant allelic frequency for the NPM1 mutated gene, which I remind is always heterozygous, and thus meaning that almost all the cells were leukemic. Best response was achieved after about 2 months of treatment with the partial recovery with neutrophil absolute number over 1,000, but persistent thrombocytopenia. And at the bone marrow evaluation, less than 5% of blasts satisfying the criteria for a complete remission with incomplete hematological recovery. However, DNA fragment analysis of the showed that of the peripheral blood showed that over 80% of the cells harbored the NPM1 gene mutation and thus belong to the leukemic clone. This phenomenon was the terminal myeloid differentiation towards granulocytes, whilst keeping the gene mutation as been previously described with since the first experiences with the FLT3 inhibitors, but how this could be reconciled with the complete responses has not been fully investigated. Looking at the bone marrow of our patients, also at this level, whilst we could observe a progressive clearance of blasts, even by flu, the VAF for the specific DNA genetic lesions remained stable over time, and in particular indicated that, again, almost all the cells in the bone marrow belong to the leukemic clone. And these cells were represented by granulocytic cells with a different differentiation stage, but also erythroblasts for about 60%. Also megakaryocytes were present, although reduced in number and with dysplastic features. To note, all these cells, normal-looking cells belonging to the three lineage of myeloid cells, harbor the mutation. And in particular, NPM1 staining with a specific NPM1 antibodies, which in immunohistochemistry allows de facto a analysis at single-cell level confirm that erythroblasts, here a double stain with glycophorin NPM1 and megakaryocyte harbor the cytoplasmic mutated NPM1 and thus belong to the leukemic clone. Thus, disrupting by FLT3 inhibitor the FLT3 signals drives a clonal multilineage terminal differentiation, which looks like a bone marrow trilineage reconstitution. This, together with the clearance of blasts, mimic complete response. We have observed a similar phenomenon also in another patient treated with gilteritinib and a patient treated with sorafenib, suggesting it is a general effect of FLT3 inhibitors and thus of the switching off of the FLT3 signal. Indeed, our observation is in keeping with the physiological role of FLT3 in hematopoiesis, which is almost absent in megakaryocytes and also erythroid precursor and mature granulocytes, and highlights a role for FLT3 ITD in differentiation RS in AML. Our observation also support and add further insight to a recent report from the group of Alexander Pear, which have described upon gilteritinib a single agent two kinds of bone marrow responses with or without differentiation, the former observing about 50% of the 21 patients studied, a frequent phenomenon. You might ask whether this phenomenon could occur also when concomitant chemotherapy is given with a FLT3 inhibitor. Here, a patient with a diagnosis of a malware NPM1 FLT3 is treated with 7+3 in association with midostaurin. The bone marrow had diagnosis with NPM1 cytoplasmic positive, a diffuse infiltration. Early during treatment, we observed the appearance of cutaneous infiltrates, then resolved, that were made mainly of granulocytes at different myeloid cells expressed in generally at low level NPM1 cytoplasmic in the cytoplasm. These cells belong to the leukemic clone as confirmed by the immunostaining with the specific anti-NPM1 mutant antibody and by the DNA fragment analysis. Also, this phenomenon was described upon FLT3 inhibitors in the first experiences, but not with concomitant chemotherapy. The bone marrow evaluation, again, the criteria, morphological criteria, also immunophenotypic and the CBC were satisfying a CRI response, which was doubted again by immunohistochemical analysis, which showed about 30% of myeloid cells expressing a clear, although weak, cytoplasmic positivity for NPM1. These cells, but also most of the megakaryocytes in the bone marrow harbor NPM1 mutation and thus belong to the leukemic clone. This was also confirmed by the value of the VAF at the bone marrow, on the bone marrow aspirates. Thus, chemotherapy can certainly limit this phenomenon, but does not cancel the phenomenon of terminal differentiation of leukemic cells. And this impact on the ability to identify leukemic cells by either morphological or immunophenotypic analysis. Thus, I think that targeted therapy is demonstrating that other form of leukemia, besides the acute promyelocytic leukemia, may undergo terminal differentiation towards granulocytes, but also erythroblasts and megakaryocytes. And this was a phenomenon not previously described, of which I think that hematologists, pathologists, and laboratories should be warned, because these terminally differentiated leukemic cells are not recognized as leukemic by standard approaches, including multiparametric flow cytometry, and thus they raise also doubts on this, the appropriateness of this methodology to monitor for MRD monitoring in this setting. I think that in the new era of target therapy, precision medicine, acting on specific signaling, cell signaling, is unveiling phenomenon, still not well described, which are challenging our approach to evaluate the best the response. And this would need, I think, prospective studies in clinical trial based on the employment of specific inhibitors to try to understand characterize better the phenomenon of trilineage, multilineage differentiation of leukemic cells, establish its frequency and clinical significance, and whether it is associated or not with any specific genetic subtype. I think that this phenomenon could also occur upon other inhibitors, like IDH1/2 inhibitors, for which at least a granulocytic terminal differentiation has been frequently described in clinical trial. Finally, in the new era of target therapy, I wish that more effort could be made to target the disease-defining genetic lesion, which are the genetic lesions which define a specific entity recognized in the WHO classification, and thus 100% associated with the disease and present in 100% of the cells, and thus that would be the real target. Exactly the target that are hit by the specific therapy of acute myeloid leukemia, NCML, and likely the reason of their success. Finally, I would like to thank patients and their family, all my collaborators and my colleagues, and all the institutions that are supporting our research every day. And thank you for your attention.
Thank you, Maria Paola, for these interesting insights on the biological consequences of target therapies. Open for questions.
I have a question for you. You suggested, Giovanni,
Okay.
you suggested, and I'm totally in agreement with you, that the best way to cure leukemia is to make a differentiation path, to introduce a differentiation in the content of the leukemia, move the leukemia to a more sensitive and more prone to pro-apoptosis mechanism. This is also the way we cure promyelocytic leukemia. This is something that we are doing with EDH1, particularly EDH1 inhibitors, getting a differentiation path and then eventually eradication or touching the leukemia stem cell. How we can integrate better this information? For instance, there are some dehydroorotate inhibitors that make differentiation. The mitochondrial machinery for energy is probably the machinery which we have to touch. There are other presentation later on that probably might focus this attention, but what's your opinion regarding touch better the mitochondrial at the energy level to promote the differentiation path? What do you think?
I think that to promote differentiation surely can be a way to switch off specific signaling that are keeping blasts indifferentiating and give them a proliferative also characteristics, and so these are welcome, but there are not enough. The differentiation alone is not enough. We need apoptosis, probably the combination with the FLT3 inhibitor with pro-apoptotic inductors like venetoclax or other pro-apoptotic drugs can better eradicate this clonal disease, because the differentiation can also give some resistance mechanisms, can also lead to some resistance mechanisms. So the new era of target therapy is also new challenges in understanding which is the best way to combine a drug and understand the phenomenon of the specific inhibitors, and in order to make the best combination to eradicate the disease.
Professor Falini.
Just a comment. I think that this study addressed the issue of the importance of the way you monitor the response after therapy in this with these FLT3 inhibitors or EDH inhibitors. So I would be curious to ask whether the MD Anderson Hospital used the same approach, using, for example, bone marrow biopsy that is able to give you this information about differentiation with monoclonal antibody, or they use just bone marrow aspirate, because some of the discrepancy about the interpretation of this analysis comes from these different approaches, I think.
If I add, can I add a comment? Certainly the NGS methodological approach will be able to identify at least the disease burden using the genetic lesions that are present, not in the subclonal, but that are present in the 100% of the cells. This can, the NGS can allow us to evaluate the disease burden. Not only minimal residual disease. This is not minimal residual disease. This is a total disease, a full disease. And we could follow this with a more modern approach than biopsy by next generation sequencing. However, bone marrow biopsies and deep immunohistochemical analysis has allowed us to highlight this event. trilineage clonal differentiation that then that last over time for 3-4 months, during 6 months during the treatment, and then the treatment was, the response was lost, or the patient died, or we had other problems to pursue the treatment. But it was long-lasting, this clonal leukemic hematopoiesis.
Yeah, so...
I'm
so
sorry, we have to
running out
cut
of
the
time.
discussion.
So briefly...
If it is very, very short.
Very short. So this is the MD Anderson approach. We don't look for the differentiation. Typically it occurs, we know, in 60 to 70% if you're searching for it, but it doesn't seem to impact, I'm talking about FLT3 inhibitors, the response or the management. So I think it's a useful correlative. Now with IDH, it may be clinical, it's different, but we don't use it to determine our treatment. We usually do biopsies and do PCR as well as flow for MRD and use that more importantly for deciding the next steps.
Thank you. Thank you, Maria Paola. Next speaker. Next speaker is Dr. Dinardo, who will discuss venetoclax in elderly AML. Thank you.
Thank you. Well, thank you all for the invitation. This has been a lovely morning. So my topic is venetoclax for elderly AML, and so I thought I would go back a bit and go through some of the original trial data that led to the approval in the United States, as well as many other countries at this point, as well as talking about some of the clinical pearls that aren't often discussed in some of these meetings. So first, I was actually surprised no one actually showed a mechanism of action slide, so I'll go through this one, which just shows you that in all cancer cells, there are upregulation of the anti-apoptotic proteins. And so in leukemias, AML in particular, you have this upregulation of the anti-apoptotic protein BCL2, shown in blue here. And venetoclax is a small molecule BH3 mimetic which binds to the anti-apoptotic proteins, BCL2 of course, and causes release of the pro-apoptotic proteins and leads to initiation of cell death, apoptosis, which can happen very quickly in patients who are very Ven sensitive. And so you can see that tumor lysis phenomenon because of the mechanism of action. So these are the two studies which I will go through in some detail. The first is the hypomethylating agent, either azacitidine or decitabine with venetoclax, and the optimal dose of that was 400 milligrams. And then the low-dose cytarabine with venetoclax study, with low-dose cytarabine given for the first 10 days, along with venetoclax going up to 600 milligrams. And again, we spoke about the Ferrara criteria this morning. Eligibility was age greater than 75 or an ECOG performance status of 2 or 3 with various different organ toxicity according to Ferrara criteria. The important thing to note in this initial cohort, the first 145 patients that were treated, is that this was a high-risk patient population. The median age is 74. There were about 50% of patients had high-risk cytogenetics, and 25% of patients had secondary AML. Although patients in the hypomethylating treatment arm study were not allowed to have had a prior hypomethylating agent. So these were patients with an antecedent hematologic disorder that had not been treated or a therapy-related AML. You can note on the bottom also that 12% of patients received hydrea prior to start. This was important because you needed a white count under 25,000 to initiate treatment because of that risk of tumor lysis. So the first thing that we noticed is the very dramatic bone marrow blast reduction. And so this was one of the first most exciting things about venetoclax with the hypomethylating agents, is that it really didn't matter which hypomethylating agent you received, which venetoclax optimal dose you received in the initial phase 1 component. Pretty impressive bone marrow blast reduction, and this is at the end of the first cycle. In terms of adverse events and side effects of treatment, there is gastrointestinal side effects, nausea, diarrhea, constipation seen in about half of patients. These are primarily grade 1 and grade 2 and easily managed. The other thing you see is myelosuppression and myelosuppression-related infections like febrile neutropenia, which potentially happens at a higher rate than you would see with a hypomethylating agent or low-dose cytarabine alone. Despite this, the 30 and 60-day mortality is quite reasonable, under 10%, and again, this very difficult, challenging to treat population. What's important to note is in the bold asterisk text is about half of patients require ven dose interruptions related to myelosuppression or adverse events. And this is just something, as you become more familiar with venetoclax, it's really important to do that end of cycle 1 bone marrow and identify whether or not the cytopenias that are present are because of persistent leukemia or are because the venetoclax combination has been so effective, you have myelosuppression, no residual leukemia, and at that point you wait a week or two for count recovery before you give the next cycle. So that's just been an important learning curve with venetoclax-based combinations, is that you're often delaying the first few cycles by a week or two to allow for count recovery. The response rates are quite impressive regardless of the genomic factors. And so looking at poor risk cytogenetics, looking at patients with P53 mutations, maybe a hint that FLT3 mutant patients are not quite as responsive, but specifically speaking to response rates, regardless again of the hypomethylating agent received, really quite impressive compared to the 20-25% or so seen with hypomethylating agents alone. MRD negativity, which again is not often described in patients receiving hypomethylating agents alone overall, occurring in over a quarter of patients, and in particular, 45% of those patients receiving azacitidine with venetoclax, which is that combination that has moved forward into the approval. And this is based on flow cytometry that was performed centrally at any time on study. And so when you look at those patients who were MRD negative, who had 400 milligrams of venetoclax with azacitidine, those also are those patients that appear to have the most durable response rates, as shown here in that orange bar along the top. And I think this is just another kind of important teaching point that more is not always better, that just because you can go up to 800 or 1200 milligrams of venetoclax and have impressive response rates, the more durable responses seem to be in those patients who are treated at the 400 milligram dose level. With overall survival shown here, quite impressive, and with the most updated data set that was presented by Dan Pollier at ASH of just over 16 months. Dr. Kantarjian showed this slide this morning, but just to compare, expectations with azacitidine alone in the AZA-001 study compared to what we're seeing with hypomethylating agents and venetoclax. The randomized study, of course, is still ongoing and hopefully will be presented later this year. 2 slides, or maybe 3, about drug-drug interactions, because it's really important when you use venetoclax to be aware of the fact that there are strong CYP3A activities with venetoclax. And so this was a sub-study that we did at MD Anderson within the original HMA-Ven trial, and so patients received the venetoclax up to 400 milligrams through day 20, and then day 21 to day 28, we dropped their venetoclax dose to either 50 or 100, and then added the posaconazole in. And so each patient was essentially their own control, looking at the venetoclax concentration before and after that dose was changed. And so this was, again, only based on a small number of patients, but you can see in the open circles is venetoclax at 400 alone, and then when you add the posaconazole, you drop the venetoclax to 75% or even more, and you can see equivalent or even higher levels of plasma concentration of venetoclax on top, and at the bottom the Cmax and the AUC, showing that there really is this strong interaction. So you need to be aware in dropping the venetoclax dose with azoles. Just a few slides of the low-dose cytarabine and venetoclax trial, because it wasn't presented yet earlier today. Again, a high rate of secondary AML. Again, under that, notice that over a quarter, almost a third of patients in this study had received a prior hypomethylating agent. About a third of patients with poor risk cytogenetics. The response rate by subgroups in this study are shown here with CR in green along the top now. And you can see that, as you would expect with low-dose cytarabine-based regimens where complex cytogenetics, secondary AML have more adverse outcomes. That is, again, the case here. So venetoclax can improve upon and synergize with the backbone therapy that you are giving. Overall response with low-dose cytarabine and venetoclax is shown here. Again, those patients who obtain a complete remission appear to have very durable overall survival with the x-axis going down to 3 years. And this now is a combination of low-dose cytarabine with the hypomethylating studies. This was presented by Steve Strickland at EHA last year, showing that patients with NPM1 mutations, also IDH1 and IDH2 mutations not shown here, have very particularly favorable response rates with venetoclax combinations. Also, perhaps splicing factor mutations, also cohesin mutations, have also been recently reported to have very favorable responses to venetoclax. And unfortunately, one of the more depressing things was that we were hoping, of course, that venetoclax would lead to particularly favorable responses in patients with p53 mutations also. And while we see impressive response rates, that unfortunately is not leading with these combinations to really durable overall survival. So that brings us to the question then, if you're able to obtain a nice MRD negative remission with these venetoclax combinations, but in some genomic categories not leading to prolonged remission, what about using this therapy to then transition to a transplant? And so along A and B here is patients treated with the DAC10 and venetoclax regimen that Dr. Kadia presented this morning, showing again with small numbers, but that impressive outcomes with a 0 100-day mortality in both the newly diagnosed and the relapsed refractory AML patients who are responding to DAC10-VEN and then transitioning on to transplant. And in italics along the bottom shows that the about 10, a little bit more % of patients in the original HMA-VEN study did go on to transplant, and so that data will be presented at ASH this year. Just one other kind of food for thought slide showing that this is MD Anderson data looking at patients who have received hypomethylating agents with venetoclax for NPM1 mutated disease, right? So patients with NPM1 mutant are particularly sensitive to venetoclax. And so when you look in this first curve of patients who are older than 65 years of age, who have received HMA-VEN versus intensive chemotherapy or hypomethylating agent alone, it really poses the question that just because a patient can receive intensive chemotherapy doesn't necessarily mean that you can't have an impressive response with the hypomethylating venetoclax-based regimen. So some encouraging preliminary data here. So in conclusion, while venetoclax has been used as a single agent in a relapse setting has fairly modest activity, it seems to synergize incredibly well with whatever backbone therapy you are giving, and in combination with hypomethylating agents in particular, as well as low-dose cytarabine, is becoming the new standard of care for older AML. There are, of course, the randomized studies which are ongoing that will hopefully confirm this benefit, and in particular, those patients with diploid cytogenetics, NPM1, IDH, 1 and 2, as well as splicing and cohesin factor mutations appear to be particularly sensitive. Dr. Konopleva next will go through resistance mechanisms and hopefully future combinations that will address some of these resistance pathways. And just as you start to use venetoclax more clinically, just be aware again of the interactions as well as ways to mitigate the neutropenia that's seen. So thank you all very much.
Thank you for the nice presentation. Thank you. Question?
Courtney, congratulations, terrific presentation. So now it's the time for my question.
Sure.
Do you think that it's time to move forward? I mean, you are presenting terrific results for all patients with all genetic, also unfavorable alterations.
Yep.
And probably seeing also the results with DAC10 plus venetoclax, that is probably more similar to an intensive induction.
Right.
What are your guesses? You gave us a lot of food for thought, so
Exactly. I think especially in patients with complex cytogenetics, p53 mutations, they are not deriving durable benefit from intensive chemotherapy. We know that. We've seen multiple different studies with various intensive chemotherapies showing that. And so we certainly don't have any randomized data yet, but I hope soon there will be some sort of comparison showing that hypomethylating agents with venetoclax does at least as well, if not better, at least obtaining remissions, and then you can then take these patients who are eligible to that curative transplant. Absolutely.
Please.
were you surprised of the particular sensitivity of the NPM1 to venetoclax? Do you have any explanation?
You know, I don't have a mechanistic explanation. I know many people, probably some in the audience as well, are working at trying to kind of investigate what the specific mechanistic basis for that is. NPM1 mutant patients just seem to be particularly sensitive to leukemia-directed therapy. So my very kind of simplistic answer is that they're going to respond well to a venetoclax combination also, which is providing kind of synergistic activity with the backbone therapy. So I don't have a great mechanistic answer, but certainly it's been well validated at this point.
Just a curiosity, do venetoclax relapses maintain the same karyotype in elderly?
Often they do, but you can see kind of some of the most common resistance pathways that we've seen have been P53 mutations. So those with P53 mutations tend to have shorter remission durations, and so they often relapse with the same kind of complex cytogenetics P53 mutations. We have seen signaling transduction type mutations, so FLT3, ITD, RAS mutations, PTPN11 is another kind of mechanism of relapse we have seen.
Also, me a short question. It seems to me that the cytarabine looks more fitting with the venetoclax therapy, particularly in 10 days. Did you get any explanation of this? Because at the beginning it was more for ASA, the combination favored. It's difficult to understand which one is better, but now the data 10 days, the cytarabine seems more
yeah,
attractive.
I think when you compare the 7 days of AZA with the 5 days of decitabine, there's no clear winner there. There were slightly higher rates of MRD negativity with the azacitidine arm, but the numbers are small and it's hard to compare. So I would say those were equivalent, and I think based on the availability of azacitidine worldwide, that's why AbbVie made the decision to move forward with azacitidine. But I think the 10 days of decitabine with venetoclax that we've been using certainly seems to improve remission rates and MRD negativity compared to like 30 to 40% in the original study. It's upwards of 60% MRD negativity in our remission. So I hope that could be in even one step forward.
And the oral decitabine will be reproducing the same data that you get in EV?
I hope so. That would be amazing.
Nice, thanks.
So,
Thank you.
Thank you again. Next speaker is Dr. Konopleva, novel venetoclax-based therapies and mechanisms of resistance.
Well, I would like to first thank Dr. Martinelli and Claudia and all the organizers for this very kind introduction. We're very happy to be here. I was happy to be part of the organizing committee, and we certainly hope that the SOHO will continue in Italy as it does in the US. So I was asked to cover the topic of venetoclax combinations, and I think some of the questions and some of the previous speakers already addressed some of it, and the need for combinations to move forward. We need to know how we improve the therapy, which so far looks so exciting. So first of all, I would briefly cover some of the lessons that we learned from the single agent venetoclax. As you all know, the trial was inconclusive. Only 32 patients were enrolled. The response rate was 19% only, although it was higher in patients who had IDH1/2 mutations, and we continue to see that with the combination therapy. These patients are much more sensitive to venetoclax in addition to NPM1. But when we tried to analyze the reasons for the failure, we did the genome sequencing, exome sequencing for patients who were primary refractory or who were relapsing on the therapy. And this slide summarized our published work by now. And as I showed, the patients who had some activity to the venetoclax, they frequently had IDH1/2 mutations and also splicing factor mutations, shown here in green. And the only 3 that did not respond had mutations in FLT3 ITD or PTPN11, which is a phosphatase that controls MAP kinase signaling. What was also interesting that people who initially responded and then relapsed, which shown here in purple, they also had similar mutations, signaling mutations, FLT3 ITD or PTPN11, suggesting that some of the signaling pathways really happen as a result of resistance to venetoclax, and they can drive subsequent no response. So of course, the first target that was easy to address was FLIX3 ITD because we have specific mutations. In this study, in the mouse, combination of quizartinib and venetoclax, which did not work at all, as you can see here in the blue line, similar to our patients who did not respond to a single agent venetoclax, the combination in red completely eliminated leukemia in the mouse. So this was further shown, as already was presented by Dr. Davar, in low-dose atirabine venetoclax trial, where people who had FLIX3 ITD, they were commonly non-responding, or patients who initially responded, they were relapsing with the newly found FLIX3 ITD mutations, which we think were pre-existing, but not detectable because of the low allelic burden. And of course, that led to the ongoing trials that are currently being performed in our institution and others, combination of gilteritinib and quizartinib with venetoclax. And we are now moving into triple combinations of HMAs, venetoclax, and FLIX3 inhibitors that may be covered in the next topic. So what are other mechanisms of resistance to venetoclax? So this is sort of simplified cartoon, which showed how the drug works, first of all. So there is a perception that BCL2 in leukemia cells and other cells could be primed and complex with pro-apoptotic family members such as BIM. And therefore, if you have a drug such as venetoclax, which is shown here by these green bars, it would disrupt the interactions between BCL2 and BIM and release pro-apoptotic family members that will kill the cell. However, there are other three members of the family, MCL1, BCL-XL, and BCL2A1, which are not targeted by venetoclax. And therefore, if the cells have even low levels of these proteins, they can be upregulated, or the clones that carry these proteins can be selected. And therefore, the cell that has high levels of MCL1, for example, it will sequester the pro-apoptotic family member, and therefore, despite the presence of venetoclax, cells will not die. So we have shown that this is indeed is the case, at least in the lab. We generated the cells that were completely resistant to venetoclax by long-term exposure to the drug. And as you can see here by Western blot analysis, in 4 out of 5 cell lines that we generated, MCL1 was upregulated on the level of the protein. We did not see changes in BCL-XL or BCL2A1, although they subsequently were shown in the subsets of AML as well. We have also shown that the cells become MCL1 dependent by BH3 profiling. And if you use MCL1 inhibitor here on the bottom, you can actually kill the cells easily with a lower IC50 than parental cells. And the same happens if you knock down MCL1 by shRNA. So as you all know, there are several MCL1 inhibitors right now in the clinical trial. This is the Amgen drug. This was preclinical paper published in Cancer Discovery. There was a Servier molecule, which is already in combination trials with venetoclax, and we are all awaiting the results of these combination trials, which we think should be highly synergistic, MCL1 inhibitor plus BCL2 inhibitor, but we're all aware of potential for toxicity because MCL1 is important for the stem cells and some other cell types. So this remains to be seen. So what other pathways are induced in resistant cells? Again, one of the pathways we found was MAP kinase pathway, and if you recall, the PTPN11, which is a phosphatase, it controls MAP kinase pathway. So we again shown that in these resistant cell lines, you can see here there's 3 resistant cell lines that are totally resistant to venetoclax. They all have upregulation of phospho-ERK and P90 RSK, which is downstream kinase. We also showed that these cells are more sensitive to the MEK inhibitors that inhibit the pathway. And very recently in our studies, we have done the single-cell sequencing, and we found that the RAS-mutated clones are being selected in patients who undergo therapy with azacitidine and venetoclax, again suggesting that activation of this pathway is important. We have completed the preclinical data combining the MEK inhibitor, in this case is cobimetinib, with venetoclax, and we have shown synergy in the cell lines and primary samples, and not so much in no effect on the normal stem cells. So this data look encouraging and positive, and that led to the clinical trial with this combination, unfortunately, which was stopped recently because of high toxicity in this arm due to GI side effects in MEK inhibition. So this strategy is not going to work in clinic probably unless other MEK inhibitors are better and less toxic. So right now we're working in the lab on the RAS degraders, hoping that they will affect at least RAS mutated AML cases. So another strategy that was explored by Michael Andreev's lab has looked at the effects of p53 upregulation through inhibiting the MDM2, which is ubiquitin ligase leading to p53 degradation. So this is a normal pathway how p53 can be degraded in normal cells. And if you have high levels of MDM2, which AML cells do, then you may have low levels of p53 despite the lack of the mutations. And some of you are probably familiar with a type of drugs called MDM2 inhibitors, one of them being idasanutlin, that binds p53 and MDM2, that binds MDM2 and inhibits p53 MDM2 interaction, and therefore stabilizes the wild type p53. Unfortunately, this does not work for the mutant p53, so again, we have this unmet need. But his lab has published this preclinical work in cancer cell showing that the combination of idasanutlin and venetoclax is highly synergistic. And they actually figured out the mechanism how it works. Of course, p53 would induce pro-apoptotic family members such as BAC, PUMA, which will antagonize MCL1. So this is one way of potentiating venetoclax efficacy. But they also showed the new mechanism in that p53 somehow, we didn't figure out how, inhibits RAS MAP kinase pathway. So again, this is another way of inhibiting MAP kinase pathway without using MEK inhibitors. And MAP kinase pathway affects MCL1 stability through two different phosphorylation sites. I don't have time to go into the details. So essentially, MCL1 is being degraded if you use nutlins, and this is one way of sensitizing to venetoclax. And this is some data from the paper where they show that in patient samples that have wild type p53, there's synergistic induction of cell death, but not in this last case, which was mutated p53. So again, does not work for the mutant p53. And in the mouse treated with these inhibitors, again, the mouse was totally refractory to venetoclax, as we saw in clinic, not uncommonly. It had some response to MDM2 inhibitor, but the combination was dramatically extending the survival of the mice. So based on that, this was taken again into clinical trial that is currently ongoing. It's a multi-center trial, is also running in Italy. Dr. Martinelli is one of the PIs, where idasanutlin in different doses is being combined with the venetoclax in elderly relapse refractory AML population. And you've already seen the slide that at the dose that we feel could be a recommended phase 2 dose, the response rate are about 50%. So there are some issues with this trial because we do see frequently cytopenias and marrow aplasia with the therapy that precludes administration of subsequent cycles. So right now, actually, the trial will be redesigned to have a shorter duration of venetoclax, and that comes back to the previous talk that we do not think that venetoclax can be administered on a daily basis for almost any combinations, whether it's chemotherapy or some of the targeted agents or even the idasanutlin combinations. So we're going to explore the 21 and possibly even 14-day cycles of venetoclax in combination with idasanutlin with the hope to get patients to complete remission and transfusion independence. So my last point is about IDH1/2 mutated patients. As I showed initially, in the initial trial, these patients were found to be more sensitive. And in fact, we enriched the trial after this paper came out. This paper was from Ravi Majeti's lab, performed by Stephen Chen, his postdoc. And he showed that the 2-hydroxyglutarate 2-HG, which is, as you know, oncometabolite produced in IDH mutated cells, it affects the enzyme called cytochrome C oxidase. It's one of the enzymes of the mitochondrial electron transport chain. And therefore, cells become dependent on BCL2. So if you inhibit BCL2, cells are unable to survive. And he showed that the sensitivity of the IDH1/2 mutated patients in vitro is much higher than the wild-type cases. Nevertheless, in our trials in combination, we frequently see that for IDH1 mutated patients, there is a common persistence of molecular IDH1 mutation, despite the fact that people are being in remission. And again, some of the data performed by Stephen Chen in subsequent studies showed that the combination of venetoclax and IDH2 inhibitor is highly synergistic in preclinical models. So we didn't do in vitro work, we just took it forward in the clinical trial that is led by Dr. DiNardo and was presented at EHA last year, where we are combining venetoclax and IDH1 inhibitor. So the study right now is for IDH1 mutated, relapsed, and elderly unfit AML patients. So as far as the schedule, we're using initial venetoclax because there was a contention that if you block IDH, you block 2HG, and therefore cells may not be as sensitive to venetoclax, which probably is not necessarily the case. But nevertheless, this is a schedule. And then there are 2 dose levels of venetoclax. With this combination, you actually have to go higher on venetoclax dose because the drug is ivosidenib is metabolizing venetoclax and lowering the plasma concentration. So 13 patients were treated, and this again, the slide was shown previously. There's a high response rate, 75% response rate in this population. Half of the patients were relapse refractory and 44% MRD negativity, with the many responses are being durable. Is that enough? It's very encouraging and promising data, but in our center we decided to add azacitidine into this doublet because we did have 2 patients who relapsed on the study. So we think that triple combination is the way to go. So I'll end my talk here. These are some of the conclusions. We think that in AML, BCL2 is the main driver for apoptotic resistance, but MCL1 is also clearly important. And therefore, one wants to inhibit MCL1, whether it's being MCL1 inhibitors or CDK9 inhibitors that inhibit MCL1 on transcriptional level, or MDM2 inhibitors that affect MCL1 on the protein level, and there are some other approaches. Unfortunately, the resistance is associated with P53 mutations, which we still don't know how to address, and FLT3 RAS pathway mutations, as I showed you previously. There are multiple combinations which already went into clinical practice, such as IDH, FLT3 inhibitors, Roma domain inhibitors are ongoing. And I didn't show you the data, but why chemotherapy plus venetoclax is so effective? Because there's some data that chemotherapy somehow modulates the levels of MCL1 and BCL-XL, and there are multiple trials right now that are ongoing in our institution and others combining chemotherapy, such as FLAG-IDA 7+3, cladribine low-dose RSC, and CPX351. So this is my last slide, which just shows you how many trials we have at MD Anderson where we're doing the combination with venetoclax. So again, on the left upper corner, you see combinations with chemotherapy regimens that I mentioned, decitabine 10 days venetoclax, which was already mentioned, and some of the signaling inhibitors, itacitinib MDM2, and 2 FLT3 inhibitors, and IDH1 inhibitors. We also have trials in other malignancies. BPDCN, which was mentioned, is highly dependent on BCL2, and we have a trial with venetoclax where we see responses in patients who are failing SL401, which was mentioned previously. It was approved last year. We're also very excited about ALL, because in ALL, our data which were submitted to ASH, with the low-dose chemotherapy plus venetoclax, we have very high response rate in elderly patients, and the responses appear to be durable at this point. Interestingly, in ALL, we're also using the navitoclax, which is BCL-XL inhibitor. There's a study done by AbbVie where venetoclax is combined with navitoclax and low-dose chemotherapy because ALL tend to be also dependent on BCL-XL plus BCL2. And Dr. Ravandi is running the trial of venetoclax plus ponatinib in pH-positive ALL, so oral combination chemotherapy-free regimens. In MDS, the studies are still ongoing, have not been yet presented. And finally, in CML, Dr. Kantarjan is leading the trial of 50 milligram dasatinib low dose with venetoclax, trying to get to the remission earlier and stop therapy possibly after a few years on treatment. And we have designed the maintenance trial. I think there was a lot of questions today about the maintenance trial post-transplant in the high-risk patients, where we will also do venetoclax and azacitidine. I'll end my talk here and be happy to answer the questions.
Thank you very much for sharing all this information. Questions, comments? Isidori.
Again, congratulations for this very nice talk. I have a question because you are one of the most recognized experts that study the microenvironment. So are you studying the effect of these drugs also on the microenvironment, namely adipocytes or the other cells of the microenvironments? Because it seems that the oxidative stress somehow has a role in the effect of these drugs. Can you just tell me something?
Yeah, that's a good question. We actually have not done much studies with microenvironment. We know that if you co-culture cells with stroma, AML cells with stroma, there will be less efficacy of venetoclax. So possibly some of these new agents, which will be covered later, E-selectin inhibitors might be effective. CXCR4 inhibitors we tried in the past, so they didn't show efficacy in chemo combinations, so we're not as excited about them as well. We're also looking at combinations with the immune approaches, such as checkpoint inhibitors, and we feel that there will be a role of venetoclax combining with checkpoint inhibitors, and also possibly with anti-CD47 type of molecules, which induce eat-me signal, and of course, venetoclax would also induce an Extin-5, which is a main trigger for the phagocytosis. So we're doing this type of approaches and looking at more at the immune microenvironment at this moment, not so much at the stroma-mediated microenvironment. I think it remains to be seen. Thank you.
A short question. Virus reactivation using venetoclax so extensively in all the combination is a matter, is a problem? Virus?
Like type CMV type
Yeah.
viruses, we haven't seen a lot of that. Now, all of our patients are on Valtrex prophylaxis, but we haven't seen CMV, so it's not as immunodeficient as one would expect. In fact, there's some data that venetoclax actually selects for cytotoxic T cells and kills some other T cell subtypes, so it may not really cause that profound immunodeficiency as was anticipated.
In the marvelous pipeline you presented, there is no T acute lymphoblastic leukemia. I know that's probably is not the arguments of your presentation, but the Australian has a very dramatic results in some T acute lymphoblastic leukemia. What's your experience with venetoclax in TLL?
Yeah, so the TLL have different subsets, as you know. So the ETP ALL were shown by tonilitide as being BCO2 primed and BCO2 dependent. And in fact, in the study that we mentioned, we treated several ETP ALL in combination of chemotherapy plus venetoclax, and we can achieve responses. And of course, all those patients are still undergoing transplant. So I think it's highly effective. In other subsets of TLL, BCL-XL is actually playing, I think, a more important role or as important role. So I personally think that combination of venetoclax and navitoclax will be needed for the other subsets or other BCL-XL inhibitors, which are now being explored in, in early clinical trials. But this will remain to be seen. So of course, as I showed, chemotherapy also affects BCL-XL levels, so maybe just venetoclax plus chemotherapy would be sufficient for any TLL. But we are highly excited about the ALL field as well, and we think it should be like a next area of study of clinical trials where venetoclax will probably be just as important as an AML. Thank you.
Thank you again. And now Giovanni Martinelli will present the role of CPX351 in acute myeloid leukemia.
Yes. No, this. There is another presentation? Or? Oh, sorry.
Sorry.
But you can go ahead.
Dr. Daver, sorry. FLT3-based approaches in AML.
So Giovanni joined MD Anderson, and I didn't know.
We were enthusiastic to have our host again.
Yeah, I thought Giovanni joined us at MD Anderson. I was like, wow. Okay, thank you. So I'm going to talk about the FLT3 inhibitors. We already discussed a lot about the data with quizartinib, gilteritinib, sorafenib. I'll go through those briefly. But I think what's more interesting to us is what's next. We have a finite benefit, but this is not enough to cure patients. Your 4-month, 3-month median survival improvements. How can we improve? But to start with, I think it's very important to see where we're coming from. Dr. Kantarjan made the remark in his closing about Philadelphia positive ALL and FLT3 positive AML and how they're similar, and I totally agree. So this is not that ancient, it's 16 years old, which in drug development is not historical. And you can see in FLT3 ITD on this large study, the German cooperative group first published less than 20% 5-year survival. So this is where we started for FLT3 ITD 15, 16 years ago. Now, it's also important, and I think this will become more and more important as molecular sequencing, allelic ratios, VAFs become more available. Now, today it may not be everywhere, but I think 4 or 5 years from now, it will be available in large parts of the world. So it's important to realize that all FLT3 mutations are definitely not equal. ITD is the one with the adverse prognosis. D835 is neutral. However, if a drug can improve outcomes, make neutral good and bad good, we will use the drug. And I'll show you the data with midostaurin where we use it in both ITD, TKD. High allelic ratio definitely is worse, but that does not mean that you don't have a benefit of FLT3 inhibitor. And it was shown that both high and low allelic ratio benefited, at least from the addition of midostaurin. We have shown the same with sorafenib. What I think is most important is the co-mutations, and it was very nice to see a lot of people already discussing this here, and I'm assuming some of this data must be available in Italy, and you're getting these broader mutational panels. And you can see that if you have a FLT3 ITD with a low allelic ratio, but you have DNMT3A or you have a co-occurring MLL or TET2, the outcome is extremely poor. This is a group almost as bad as your TP53 adverse cytogenetic. On the other hand, if you have an a FLT3, even in high allelic burden, but you have a biallelic CEBPA or a co-occurring NPM1, this patient may be intermediate, possibly even favorable. So I think it's very critical to look at the co-mutations that occur because this can drive your outcome very significantly. So what are the steps that happen? So just like Philadelphia positive ALL, which was a few years before FLT3 ITD in its development path, the first thing we started doing is to do allogeneic stem cell transplant. This is a paper from the German group where they showed among patients who had a FLT3 ITD mutation, especially those who are NPM1 wild type, these people, when they had a donor and went for transplant, had a finite benefit. So they're going from the 15-20% 4 or 5 year survival to 30%. So okay, improvement, but still doing worse than the general non-FLT3 mutated AML. So this is not enough. The next step, of course, is the one we have all discussed, is the FLT3 inhibitors, multiple of these. I think it is important to know the difference between them, especially because the type 2 inhibitors, specifically sorafenib and quizartinib, do not target, as far as we know today, the D835 and the F691. So the main mechanism resistance or escape, at least one of the main mechanisms in about 40%, is acquisition of a TKD or a F691, which is the activation loop mutation. On the other hand, the type 1 inhibitors, especially midostaurin and gilteritinib, both of which are approved, and crenolanib, which has some early encouraging frontline data, do target both ITD and D835, which only means that the mechanism of resistance you see with these drugs is different. So there has been recent data showing that RAS mutation, BCR-ABL, and TP53 may be the main mechanisms of resistance to gilteritinib. This was published in Cancer Discovery by a few colleagues of ours. So what are the different kinomes? And you know, a lot of people talk about this, and if you try to match this with the clinical data, you basically cannot. So for many years, we saw these kinome profiles, and if you look at this, you would think, wow, gilteritinib is such a broad kinome, it's almost like lestortinib, and so it should be less effective, but actually we see that's not true. Gilteritinib is very, very effective. On the other hand, drugs like quizartinib are highly focused and have a high degree of specificity, but they may not be this effective. So the question is, are we getting all the benefit from FLT3 inhibition purely? I think most of us at MD Anderson in the US actually don't think so. We think there's a lot of collateral microenvironmental mutational suppression ongoing, especially with sorafenib midostaurin, where we do see activity even in wild type, and there are phase 3 studies looking at that. From the approval point of view, midostaurin is approved in the United States for frontline induction. It's a good drug, but we think we can do better, and the better are gilteritinib, quizartinib, maybe crenolanib, and gilteritinib is approved, as you know, in Japan and US, and quizartinib only in Japan at this time, was not approved in the United States on the recent FDA review. So the next step was adding the FLT3 inhibitors. So we all know the RATIFY study, you know, we said, let us add the FLT3 inhibitor and do stem cell transplant. What will the outcome be? Can we improve these people further, just like we did with imatinib, ponatinib in people with Philadelphia positive ALL? This is the design. We don't need to go through the details. The midostaurin is given intermittently, day 8 through 22, and this study included induction, consolidation, maintenance, and a large proportion, about 30 to 40%, did go on to maintenance on both arms. So we do see here now, with the addition of an FLT3 inhibitor, we get a survival improvement. It's a marginal improvement when you look at the overall survival, 7 to 8% absolute benefit, but this was the first drug that got US FDA approved in AML. After that, we had the 7 or 8 other drugs, and this was conceptually very important to show that a targeted therapy did have activity in AML. Of course, now we have IDH 1 and 2, as well as gilteritinib, quizartinib. The other important clinical point to make here is that there was an equivalent proportional benefit in people who had high ITD, low ITD, which in this study was defined a little bit differently. It was a cutoff of 0.7. We are reanalyzing it with 0.5, and that data will be shown probably at this ASH or next year, and also in TKD. So what I'm trying to say is important here, that if you have a low ITD, those people did well to begin with, but they did better with the midostaurin. If you have a high ITD, those people did bad to begin with, but they did less bad. They did not do well, but they did less bad with midostaurin. So the point is, you get a proportional incremental benefit with the FLT3 inhibitor in all these patients. So we recommend in the community to use the midostaurin across all the mutation, ITD, low, high, and TKD. Now, to me, this is the curve that you have to remember, and maybe I should have put it next to each other, but to the curve that what the Germans had shown 15 years ago, where in FLT3 ITD newly diagnosed, expected survival was less than 20%. Now you can see in a large number of patients, not in a one-center study, this was an 80 to 100-center study, if you give midostaurin, you go to transplant, then you can talk about 70% 5-year survival, and this was a big number, 100% people who get transplant in CR1. So this is total therapy kind of approach. You cannot do one intervention, get the benefit. You have to do the TKI, try to take them to transplant in CR1, and then you really can go from 20 to what we're seeing at 70%. What else? So there's a next step coming. So sorafenib, as you know, Dr. Avandi in our group has worked with quite a bit and published. This was actually an NCCN guideline, it still is for many years, azacitidine with sorafenib, relapsed refractory frontline patients, about 45% response rates, which was quite encouraging when we didn't have gilteritinib, quizartinib, and is reasonably well tolerated in our experience. Also, sorafenib is being used in a frontline study in non-FLT3 mutated, so all comers, which was majority non-FLT3 mutated, and is showing that the broad kinase profile could be beneficial across the board in AML. And there are updates from this SORAML study by Dr. Christoph Rohlig that will be presented, and the overall survival seems to be trending better and better. But what can we do next? So we said transplant, midostaurin, you have good outcome. Now, what about doing post-transplant maintenance? This has already been shown twice today. The point is that adding the third part of the total therapy seems to further improve your outcome, and you can start talking about 70, 80% long-term cures in these people with TKI, transplant, and post-transplant TKI. And this is the approach we are doing at MD Anderson, and with the use of gilteritinib, quizartinib, and others, we think this will further improve. And it's not unlikely that a couple of years from now, or even now, we may say it's a good thing to have FLT3, and this will not be an adverse marker anymore. So in a couple of quick slides, we heard already from Giovanni and others about the QuANTUM-R. This was the relapse quizartinib study. The study was done in people who were high risk, meaning that they have to have relapse or refractory within 6 months of induction. They all had to have a standard induction anthracycline cytarabine, so a difficult population. And I think what's important is that this was a single oral agent being compared to traditional chemo, FLAG, IDA, MEC, which was the majority, and then a few people with low-dose cytarabine. So conceptually, this is very important to us because we're trying to show that an oral therapy, even though single, can beat 3-drug IV chemo. And the study did meet its primary endpoint of overall survival. The benefit, again, like you see with the midostaurin frontline, was small, 7%, same number, absolute benefit here at 1 year. I think from response point of view, we were all very happy because what we saw in the phase 1 and 2 was replicated, almost 50% marrow remission rates. One of the issues we know with quizartinib is that it causes myelosuppression. We think through KIT inhibition. And so the true CR rates in this population is lower. As was discussed, this was after much debate, discussions, and steering committee meetings. not approved in the FDA, but there is a frontline study that should be reading out at some point middle of next year with quizartinib with induction, and hopefully that will be more strongly positive and we will see where it goes. On the other hand, with gilteritinib, which had a slightly different design, majority was similar, but it did allow people who had relapse at any point in time, and it did allow people who may not have had anthracycline cytarabine, but I would say 80 to 85% of the patients matched to quizartinib and gilteritinib. The control arms were exactly the same, which is probably because these were developed in the same time frame, and you see here, again, very encouraging marrow remission rates, 50% to 55%, very similar to quizartinib, but the difference is you do see more CRs and more CR with partial recovery, what we call the CRH from the IDH world. And so this was quite encouraging that people did have count recovery. The survival curves, as you see, do look more separated. The median survival was 9.5 to 5.5 months, and based on this, the drug was approved. Another important thing that was again reinforced in this study, although the subset is small, is that adding gilteritinib post-stem cell transplant further seemed to improve your outcomes, and you could then see maybe 35-40% 2-year survival in a relapsed refractory FLT3 mutated patient with a single agent FLT3 ITD. So this is encouraging. I'll skip this one. So I think this is what's important. What are the next questions? So most of these studies, the first question is, these were done in people who had not received prior midostaurin, because the timing of both Quantum-R and Admiral was such that midostaurin had not been approved or was just approved at the end. So if you look at these studies, only 4 to 10% of patients in both the phase 3s had received a prior FLT3 inhibitor, such as midostaurin or sorafenib, which is not the real world practice in 2018-19. We know that 80-90% of our people are getting a frontline TKI. So our fellow Dr. Al-Fayez with us looked at some of the outcomes, and what we do see is if somebody had received induction, 3+7 FLAG-IDA, CLIA, whatever induction was done with midostaurin or sorafenib, then the chance of achieving a marrow remission is lower. It's about 25-30%. This was later confirmed by the small subset analysis from the Quantum as well as the Admiral. So I think it's important to level set your expectations. These drugs work, but the response is not going to be 50% like we were getting with 3+7 alone once we add the frontline TKI. The other important thing, which I think has been the highlight of the day and repeated many, many times, is that combinations, whether it's with HMA, low-dose cytarabine, or with high-intensity chemo, are always showing better outcomes. So we have a study of quizartinib with HMA where we see in the relapsed population, first salvage, without a prior FLT3 exposure, response rates of almost 70%, CR/CRc rates. But if they've had a prior midostaurin or sorafenib with induction, with their first induction, the response rates are lower, but still about 30 to 35%, and the same with sorafenib-aza. So if you're using a combination, I think you can still get between 30-35% marrow remissions, which is reasonable, and this is probably the way to use these. And as I said, this was confirmed by the phase 1 study where they did have about 45 patients who had received prior TKI, mainly sorafenib at that time, some with midostaurin, and you see the CRc rates are 30%, similar to our own analysis. So this is important as we develop the next generation of trials in people who have had prior midostaurin, and we have to have futility analysis that have a good level setting. What about frontline therapy? So we know 3+7 midostaurin is approved here in Italy. It's being used quite frequently across the world. And if you look at some of the, remember, this is phase 1b data. This is early data. We don't know if it will continue, but it looks very exciting. 7+3 with gilteritinib, 7+3 with crenolanib. Both are showing 80 to 95% CR and CRP rates. And if you look at the crenolanib, which actually happened to be the one that was done the earliest, you see a 2 and 3 year survival that has now been updated a couple of times being maintained. So if this is true, then the next group of phase 3s that are coming, which are basically gilteritinib 3+7 versus midostaurin 3+7, crenolanib the same thing, quizartinib the next thing, same thing, we may be seeing very exciting 80% or more survival, but I don't know. We have to wait for the phase 3s. This is another approach that we're very excited about. Marina mentioned some of the triplets that we're doing. So those are based on the doublet data that we have with HMA quizartinib, and there's a lacewing study looking at a doublet with HMA gilteritinib. And if you remember, as a single agent in relapsed FLT3 ITD, we have about 45-50% CRc rates. Here, we're getting about 60% in the relapse and 84% CRC rates in the frontline setting. Small numbers, but in the frontline setting, the median survival could be above 20 months. And as you know, with HMA-VEN, could be 18 months. So the next question is, how can we potentially combine these three drugs going forward? And in the relapse, where we know it's 6 months as a single agent, we have about double of that at 12 months with the HMA. So our advice would be to do the combinations, ideally in trial with HMA or low-dose cytarabine, not single agent. I'll go quickly through this. We already discussed this, that venetoclax, we think mechanisms of resistance are through FLT3, RAS, P53, and others, and this has led to combinations of VEN with GILT, with QUIZ, and the triplets with HMA. Another important drug, I think, is the MDM2 inhibitor. This is a study I think some of the groups in Italy are participating in, Giovanni, Claudio, others, of an MDM2 inhibitor in combination with quizartinib based on a lot of encouraging preclinical data in the relapse refractory FLT3 ITD population. We think the synergy, as you can see from the mouse models by Dr. Andreev, is quite dramatic, and the survival was maintained with continuous dosing, and this is an ongoing study. So the last slide, two slides I have here is looking at sorafenib in people who are not FLT3 ITD mutated. This was the Sormil well-known study. You do see that the relapse-free survival is dramatically improved, but overall survival at this early time point in the Lancet Oncology paper had not been improved. There is follow-up now showing that there is an improvement. And I think, as has been discussed, FLT3 is important, but it is not standalone at all. BCL2, CXCR4, RAS, RAF, PI3, PIM kinase, there's a whole host of other pathways, and I don't think it's a distant future when we're going to be really selecting personalized treatments based on which of these pathways is playing major roles at baseline, at diagnosis, or at resistance. And in the end, you know, people say, which is better, what is better? None of these are curing the patient. So even in CML, where with imatinib you have 92% people who get potentially long-term functionally cured, we still find the utility for dasatinib, nilotinib, bosutinib, and ponatinib. For sure in FLT3, where less than 10% are being cured in the relapse, there is utility to have all of these drugs and combine them. And I think we would like to have as many as possible to improve the survival. And with that, I will stop. Thank you very much.
Thanks, Naval, for a nice presentation. If there is one burning question,
if not,
we will stop a bit.
I have a,
Sure.
Sorry, you spoke about the co-mutation. So you invited to put attention on co-mutation. Can you give some indication on newer attention?
Oh, you mean it's a newer emerging?
How do you divide in terms of commutation?
Yeah, I mean, so if somebody has, at this time we don't change. So our frontline induction in a fit young patient is with FLAG-IDA or CLIA, with gilteritinib is the one we're using now, or quizartinib. We have both studies, and potentially we're trying to incorporate venetoclax into that. So we think, now again, the question is, when you have such a total therapy, will it matter, or will these mutations no longer matter? So those are ongoing, and we have to wait for the data analysis. And then for the older patients, we're doing now HMA with VEN with a FLT3. So again, we think that the triplet will potentially overcome it. The patients I'm most concerned about, I will say, are the two, are RAS and TP53. And we are seeing, even with HMA quizartinib, this should be published soon, that population who has a RAS at baseline, PTPN11 baseline, TP53, they may respond, the duration is very short. So these three mutations seem to pervade venetoclax resistance, IDH resistance, FLT3 resistance, and maybe the combinations will overcome them of all three, but maybe not, so yeah.
We will stop to get a coffee break, and we will restart with a shorter than my presentation. Felicito Ferrara, unfortunately, is not able to reach us, and so we get the next session after the coffee break. Thanks.